Good morning, everyone. Welcome to episode 29 of Digital Health on Air. My name's Aditya. I'm one of the founders and CTO here at Luma. And I'm joined by Mike Cordeiro, Senior Director of Interoperability Market and Strategy at MEDITECH. Today, we're going to be getting his expert opinion and his perspective on data exchange and where it needs to go from here. So, Mike, so excited to have you today.
Yeah, thanks for having me. It's great.
So you've been at MEDITECH focused on interop for almost 15, 16 plus years. Tell us a little bit of how this became your focus area, how you stumbled into this, and maybe once we'll get your background, just something you've been really proud of about the journey you've been on.
Yeah, so I've had the opportunity to kind of be part of MEDITECH for most of my professional career, typically in some type of technical role. And a while back, I had the opportunity to come in and work in this group that was managing, I guess, transactions to and from EHR to medical devices or reference labs. Yeah, so it wasn't even called interoperability.
70 type of things, or
yeah, it wasn't even called interoperability at the time. It was called we used to call it NMI, right? Non-MEDITECH interfaces. And the point, just like I've had the opportunity to kind of see things grow from that to this phenomenon called interoperability to now talking about FHIR and RESTful APIs and national data exchange. So it's quite interesting to see how it kind of this journey, right? And what was super exciting for me is that I had the privilege to be part of the team here at MEDITECH that launched a data exchange network in Canada and now brought that here to the States with Traverse Exchange and just talking about interop in a national scale, as opposed to, back in the day when we were just trying to figure out how to push an order to a reference lab. So.
I was going to say, I've seen on LinkedIn and the other places that you've been talking about Traverse a lot. And in one of the questions I wanted to make sure I asked you in this career of yours, what is something you're exceptionally proud of? You brought Traverse up unprompted. So yeah. I was curious to get your take on that. Just, it sounds like something that you're proud of and something the group as a whole seems very, very passionate about.
Yeah, again, just kind of dating myself here, but
the gray hair dates me quite a bit.
Yeah. So I worked on a team for MEDITECH that introduced the first kind of structured document exchange using a CCD, and it was between health system here at MEDITECH in Massachusetts and kind of exchanging with a larger academic in town. Mm-hmm. And it was really just point-to-point exchange, trying to get this thing to work, right? And figure out, is it going to go anywhere? And, fast forward, government gets involved, starts rulemaking and regulating around data exchange. And, we start exchanging CCDs, and that's great. It serves a purpose, but there are flaws, right? And so,
yeah, sure.
I guess what I'm proud of is the fact that we've kind of seen this thing grow, right? From just kind of this pilot to this using it nationally and kind of it being mandated to now adding technology that improves it further, right? And reduces burden, the document burden, and leverages exchange frameworks and again, just puts us at scale and ultimately solving problems, not just for a patient, but for the health system, relative burden reduction and other use cases like patient engagement and stuff that we do with you.
Totally. Yeah. Yeah, no, absolutely. One of the things that I've heard talking to, certain hospitals, single, critical access and about that size is one of the challenges they often face is if my patient went to a ED or somewhere else in the community, but they came back to me for primary care or vice versa, how do I even know that? How do I see the full patient record? And it's that physician burnout and the physician burden that seems to be a really massive pillar in, why interop even matters, right?
Right. No, for sure. And that's kind of what we're solving with this network that we launched, like Traverse Exchange, right? We're ensuring that you have data access so you can get insight as to, did my patient go to a scheduled care setting, what was done, what happened. But the other kind of factor is that it's not just about, the plumbing to get the data. It's then making that data usable and not having that clinician have to read a 30-page document to find the salient data points, right? It's get that data into a construct like FHIR and then be able to actually surface up the the salient point within workflow. And that's
I
essentially what we're trying to achieve.
comically, I comically extracted from my healthcare provider and from their portal the CCDA just because I'm a healthcare dork. And I'm like thumbing through this 900-page document. I'm like, oh, that's right. I did do a COVID test here in 2020. And I was like,
Yep.
I don't know how anyone can be consuming this in a reasonable way, right?
100%. I've had so much experience, especially with my children, and trying to download their records for school, and they'll make the files too large. And so, yeah, it's sad though. Like we're talking about like the challenges we had with managing that much data, but a clinician,
Yeah,
that's what they have.
I
Yeah.
mean, yeah,
Yeah.
exactly. We're doing this and we can open up XML documents and parse
Right.
through it. Good luck to a doc who's just trying to figure out if you've taken, if you've had Tamiflu before, right?
Exactly.
Totally. So when you started in 2009 in this journey of yours, you were saying, starting with this NMI, non-MEDITECH interfaces to 2024, rounding into 25. What's some of the biggest change you've seen kind of like in the interop community and I'll kind of zoom that out a little bit to the interfaces community in general. Like there's probably some just like manifest trends that have that how people think is probably quite a bit different. Is probably the quickest way to say that.
Yeah. I think that um, when I first started off doing interfaces, like air quotes, it was kind of this extra thing that people, we sometimes have to have conversations like, why aren't they just using the EHR or tool?
Sure.
Why are they like, it's just an additional adjunct that people didn't quite understand. And I think that as data became more powerful, right, within healthcare, right, for decision making, for
Sure.
access to like interop started to grow, and it went from NMI to interoperability as a concept. I think in like kind of reflecting, one of the things that kind of made interop blossom, right, was actually government getting involved and
Yeah.
saying you shall exchange data, that a patient shall have access to their data using an app of their choosing, right? You create Now we're creating these national frameworks. So I think, you know, folks talk about government being involved as kind of sometimes a barrier in that, we're just trying to meet regulation and check boxes and do things.
Sure.
One of the things that I've been doing as I've been, we're entering conference season and I've been talking at MEDITECH Live, it's, government ultimately kind of, in my opinion, push innovation for health IT forward a little bit by putting some mandates in place. So us as the health IT community should really be looking at what those regulations are and those mandates are and actually leveraging them and using them to help advance tech, right? So when Tefka's talking about national data exchange and, some folks are still talking about pushing the CCDs back and forth, I'm like, you should really be leveling up. And that's kind of what we were trying to do here is, take those structured documents, put them into a FHIR construct, use them more meaningfully instead of just checking a box saying I pushed a document.
Saying like meaningful use too, I'm done.
Yeah.
Right.
Yeah,
actually,
exactly.
It's kind of like in that whole process, we sort of lost the actual meaning of the word meaningful use, right?
Exactly right. Actually, they took it away, right? It went to promoting interoperability now.
Totally. And like it's hard to and I understand, and I think one of the things, kind of maybe transitioning to another idea that you're leading us to, is MEDITECH's kind of really been very forward leaning, and they kind of, in my mind, stand out as a supplier of electronic health records about how to make FHIR as a useful construct, an actually meaningfully useful construct, and how to iterate on the development of whether it's Tefka and which how you've done with Traverse or Argonaut scheduling kind of capabilities.
Yeah.
I think one thing that's really stood out for me is it's not fixed in time. It's a actual progressive capability that it gets better. So what's the mindset on like how to evolve a good API and a good set of interop there?
Yeah. So, I always believe in standards and adherence to standards. It's always served us well throughout the years. And so I think, first of all, when possible, right, adhering to standards like FHIR is probably the first thing we want to do. And there's many reasons for that. Obviously, it helps with development. It helps with deployment. It helps with engagement with from an EHR perspective with the vendor community relative to how you're going to interact with us. It also then allows us, it's not just adhering to standards relative to the payloads, but then, like you just said, Argonaut IG for FHIR scheduling.
It's like how it actually gets
exactly. So working with industry work groups and the vendor community, and like to define those implementation guides so that those deployments are understood where it's not the worst thing about in my opinion, interoperability is like when we come up with this great kind of data flow and architecture or how something should work, and then we go to deploy it, and there's just months of discovery. Oh, we didn't think of this, or this is error.
Totally.
So having this implementation guide that we're all following, it's all following the same rules, helps with that. But I think the other thing is having an environment where we can actually test and prototype with the vendor community and actually work collaboratively, because that's what we do with you guys, right? And we had that Argonaut IG as a
but it's a piece of paper. It's not software, right?
But it's you, it's Luma, it's MEDITECH being like, all right, well, let's stand up this base. Now what do we have? And like iterate on it. And this, and we're still doing that, right? We still kind of have
it's not a finished process, right? And most software isn't, right? It's there's always forever innovation and expectation alignment that has to happen in software development, right?
100%. And so I think when possible, using standards, when possible, deploying those kind of understood implementation guides, but there needs to be back and forth collaboration on kind of what the big picture is, because like you said, it's a continued evolution.
One thing that's always struck me is MEDITECH has always presented yourselves into the developer ecosystem, which is where Luma sits, as a peer or partner in the process. Working collaboratively on, hey, exactly as you said. And I think for the audience, it's a little bit of an explanatory bit there is really, really helpful, which is as we work together, how does the software, the MEDITECH software and the Luma software work in a hospital setting, in an ambulatory setting, and how these pieces come together? So this like kind of really collaborative piece there, I think has been it's been a huge benefit. And I think how others can take advantage of the innovations that you guys are doing. One of the things I like to say, and I'd be curious to get your take on this, Mike, is like interop is, I would love to take advantage of it exclusively for the benefit of Luma, but it's actually an all boats rise scenario, right?
Right. And I mean, the work we do with you guys obviously helps inform like, an integration use case, which might be patient access or patient engagement, but
scheduling or whatever, right?
Exactly. We're using a standard, we're iterating on it, but what we do with you guys, can be replicated and used elsewhere, right? And it's really not about, this is a specific API to Luma and MEDITECH. This is the API for how we're going to do patient messaging.
Topic area A, right?
Exactly. And the thing is, like, it's not just MEDITECH kind of coding in a silo and says, okay, now you must use this the way it is, right? We're actually collaborating on how it actually should be used relative to the use case, right? And not as a mechanism for just these two vendors to communicate.
Totally.
So, yeah.
So one that's always struck me, and I've always wondered how you guys, as suppliers of electronic health record technology, so every EHR is different, as it should be, right? Like there are various pros and cons to using every system, but the standards are sort of, I jokingly sometimes call them like airplane food. They're good enough for everybody, but like no one's gonna like go out of their way to buy like a meal from an airplane, right? But they're good enough. So how do you guys think about representing the uniqueness of MEDITECH in kind of a standards-oriented way?
So I guess that's a tricky thing, right? So one of the things we're really proud of is MEDITECH, as an organization, participates in a number of industry work groups, right? Yep. We try to do as a community, right, and not MEDITECH as a bubble dictating to others. But to your point, you work with a number of EHRs, and we've had this conversation that maybe the way this API is called and the data is used might be a smidge different with you guys than it is with another vendor EHR. And I think that there needs to be some flexibility from
our side of
you guys, exactly.
Because
ultimately we can't make our EHR function exactly like someone else's, and our concept patient IDs and things might be different. And
completely,
I think, and for me, this was kind of maybe a learning curve here, but initially, when we were talking about interfacing using HL7, traditional 2.x HL7, and it's like the 80% standard because you're always negotiating something.
And then it's the 80/20, but also the 20/80, right?
Exactly. And I had the opportunity to kind of lead for a period of time here the service and deployment teams, and it was daily. I was approving large custom lists because of that the 20% negotiation. And then when we started
Z segment that we're gonna do this one wacky thing on,
yeah,
right?
my aversion to Z segments, yes. But uh, but when we started talking about RESTful API and RESTful API integration and Fire and all this stuff, I'm like, oh, this is great. We're going to create these implementation guides. Everyone's going to use that implementation guide, and it's going to make it so much easier, right? I mean, I think maybe that was a novel idea, but it's not necessarily true because, to your point, there's a little bit of
I also think if HL7 was 80/20 and in practice it was 20/80, Fire is 95/5/5/95, right?
No, agreed. And I think the other interesting thing too is it's like, to your point, you're right. It's closer, and but I'm also intrigued at the amount of hybrid deployments we have out there for a specific use case, right? So it's here's this set of API to perform this function, and you might have I don't know 20 different resources you might be calling something differently, right? But that needs to be complemented with some other form of a transactional interface or another methodology. So I think, and that's something that we do with you guys now, right? We're trying to figure out, okay, well, we're having to plug in this transactional interface here as a complement. How do we make that RESTful? And then we're like, oh, well, there isn't really a standard for it. And so you end up with this, like, some Fire, some proprietary.
But we're still, I think, trending, we're not 80/20 anymore, which is great. One of the interesting things about Luma is we have 700 odd customers, and we've probably done less than a dozen HL7 integrations in the lifetime of the company, right? Because we've very much leaned into this concept where APIs are going to be the way that healthcare scales. And I think that's one of the actual really important elements that I hear from kind of what you're talking, Mike, is EHRs are unique, right? And like providers love some of the uniqueness of them, the workflows they enable. And so there is a need for, a little bit of like special thing for, there, like healthcare isn't like a one size fits all thing. Maybe the TLDR on that. And there has to be some room for that is, maybe a little bit of transactional interfaces, maybe a little bit of this, or, maybe a flat file in this case, right? And, But at the end of the day, yeah, let me try to get those as close to zero as possible. But, okay, well, this is really fascinating. I think the way that we take standards, make them applicable. I think that really what you guys have done really leans into a lot of the philosophy we've kind of continued to build our company on. But where do you think, I should say, we're in the maturity cycle of interop? Like, where do you think, your career is a really good, like panorama of that, really, right? NMI, HL7, Fire, implementation guides, TEFCA. Like, how mature are we in this journey?
I think we have a ways to go still, right? I think
that maybe was the obvious answer, right?
Yeah. I think for me, what I kind of am looking at, and I'm hoping what 2025, 2026 will bring is wide scale adoption of this national exchange framework beyond structured documents. We know that, and ultimately leveraging the trust element of these networks to be able to and be able to not just share data at scale using Fire, but using. And the other thing is, and it's an important use case, which is that treatment use case, but leveraging these networks to at scale deploy other use cases like individual access services. MEDITECH's been responding to IAS queries for years, but there hasn't been a widespread adoption of it, right? And for you guys, like patient engagement, right, in your apps, and like being able to just deploy at scale and leverage the network to do that. Those are the things that I'm hoping.
So if you survey kind of what you see in 25, 26, both in terms of the regulatory universe, also like the standards body, because I know you're very active in a lot of those as well. What are the things that are coming up that maybe get you most excited?
I've been spending some time now learning a bit about AI, right? Because it's kind of what's out there, what's being discussed.
It's in the water. It's definitely in the water.
Yeah, it's in the water. But, I think that's definitely a tool that folks will be leaning on, especially technology is going to be one of the solutions to help with, burden reduction for hospital staff. It's going to be the solution. And when I say technology, I really mean data, because
Yeah, sure. All this stuff sits on top of that anyway.
right. It's going to be solutions for how organizations maybe get more efficient, get out of the red a bit. It's really how you use data, present data. And so I think that technology is going to continue to advance in how and enable health systems to actually use data as a tool and do it in an intelligent manner. I think that's going to be based on, you know, the way we surface data to be used. So I'm saying, like, for a RESTful API, we know where probably FHIR is the right thing to do there, or a JSON format, but AI is probably a flatter file. And like, just having the tools and the mechanisms to be able to efficiently and effectively share data for specific use cases, and then being able to turn those on at scale. I think those are the things we're going to be seeing. One of the generative AI use cases there is also thinking about, like, how do we use that to help summarize these large CCDs, right? So.
That'd be a great use case, honestly.
Yeah.
Even for my own structured documents, I'd love that.
Right.
So when you think about the way that some of this stuff is evolving, we've talked a lot about technology, talked about a lot about policy. One thing that I want to like tuck in is like kind of maybe one of our closing comments or closing topics is the economics of this.
Yeah.
There's a lot of HHS like recently posted like a buzz blog or whatever they call it, where they're talking about like, making sure that the interoperability is available at like reasonable economics and that sort of stuff. And I applause and plaudits to MEDITECH for always being very upfront, very clear about how that works. But there's probably some very intentional thinking that's went into, how to make this like work at scale on the economics of it. So I'm kind of curious to get your take on just kind of like, how do you guys make that work? Like, how do you think about that? How do you make sure there's an equitable playing field for all third parties, Luma, our competitors, people who do different things than we do?
Yeah. So we, one of the things that we did when we created a public testing sandbox, we call it Greenfield, right? Mm-hmm. Which essentially has a number of API and implementation guides against how you can work with MEDITECH for specific use cases, right? You guys are
totally.
One of the main principles behind that was we wanted to develop an ecosystem that would allow innovation.
Sure.
We look at Expanse, our EHR is not a closed box EHR, but a platform. And we know that health systems need to build on that platform. There are niche things out there that we're not going to be able to do, right? You guys excel at various tools for patient engagement. And if a health system thinks that, hey, Luma is the right fit for our patient engagement strategy, then we want to be able to allow you to plug in there, as well as anyone else, right? That's a complement to kind of the workflows. And what's important is that kind of the relationship that we have with you through Greenfield is we're innovating and we're leveling up health IT and not putting in economic barriers that would make that difficult. And one of the things that I've been talking a little bit about, and like, Helen Waters, our CEO, talks a lot about is like, tech equity and making sure that the community hospital has access to technology, at not astronomical cost. Yeah. So if we were to put cost barriers in for you guys as app developers to innovate, you're going to pass those on and then make it.
And no one really wins there, right?
No one does. So I think, and it sounds kind of idealistic, but we've always had this in our DNA here, is like, just want to do the right thing. And so the right thing is to have an innovation platform. And that's kind of what we do. Now, we know we're not perfect. And I know I talked a little bit about, or mentioned how from a technology perspective, we're always collaborating on how to level it up. But I mean, when we're talking about our engagements through the sandbox and our partnerships, and those are things we talk to you about. What does this work? Is this not working? Like what, and run ideas by you, just relative to just even those business terms or the business side of it, not just the tech. So the point is, this is kind of an environment where we're growing with our ecosystem as a community, right? And not something that we're just, dictating.
Like that. I'll say two things about this as kind of being on the other side of the table. This is one, everyone we've ever talked to at MEDITECH has been incredibly consistent in this commentary, which is like, we're building a platform to allow folks to build on top of. And then number two is we're doing this in the service of our customer partners, right? And I think like across the board, everyone in MEDITECH has been very consistent about how you take these capabilities and actually do something for the better good. And we all know like there's salaries that have to get paid, right? Like that makes total sense. And
Right.
OpEx costs and servers and all this sort of stuff. And we're happy to like, subsidize part of that as part of this equation, right? Like that makes total sense as I would if I consume Azure services, right? And but I think like the one thing that's really stood out for me for the MEDITECH and the whole MEDITECH squad is just the consistency around focus on making your customer partners like successful and understanding that Expanse is like the core of your, your system of truth and your system of record, but there's other systems that sit inside the health IT stack.
Yeah. And I think that's part of kind of our pillar for how we kind of view innovation and collaboration with the app community. So
I love it. So, Mike, let's maybe wrap up with,
yeah.
with some final thoughts here. We've covered a lot of ground in 20 odd minutes. Public policy, data exchange, your history, economic models. As kind of a final thought, final question, we talked a little about 2025, what you're most excited for. You're about to hit the conference circuit this year. Like, what do you hope to see from the industry and kind of the interop universe writ large as we round out the year?
Yeah, I think one of the things that we're obviously working with some of our customers on pilot programs, but I think healthcare, not just health IT, is going to evolve, right? And we've talked about hospital at home and virtual
Oh
clinics
yeah,
and
yeah,
all those
yeah.
concepts for years. I think we're there. We're and so I think especially I'm expecting to see a lot of that. How are we better integrating the EHR to this virtual experience, at home or virtual nursing? So I think there'll be a lot of buzz around that. And I'm sure it's something that you guys might. No, I don't.
Yeah.
I don't have insight into your product roadmap, but I'm sure it's something that you're looking at, right? How do
Yeah,
I?
and honestly, to the points that we've making all day, like couldn't be a better use case for world-class interop.
Yeah, for sure.
Yeah. Mike, thank you so much for joining us today on episode 29 of Digital Health on Air. Your insights, your thoughts, your experience, so invaluable. Looking forward to sharing it with the rest of the digital health community writ large, and looking forward to seeing you in the fall conference circuit as well.
You for having me. This was great.
Awesome.
Bye.
Talk soon.